written.
Good afternoon, everyone. I can't see anyone. We all decided we'd make a much less successful target when we were hidden down here behind everyone. No, they didn't decide that. I did. Well, this is part one of a four-part series that's entitled Continuing Care 101, which the name doesn't really mean anything. It's just an educational series about Cedarfield, continuing care retirement communities, the various parts and pieces of them, how they work. There were four things that we had in mind, that I had in mind. One of them was to talk about the levels of care and the transitioning, how people get back and forth between the levels of care. And so that'll be an upcoming series. We wanted to talk about the rehabilitation household that's being constructed now. I know there's a lot of questions about that. And you've already had some education about how Medicare works. So we want to talk about that. The fourth one I think is less defined, but the other we wanted to talk about was how people receive interventions in their home when they don't really need the services of assisted living or of the healthcare. And so in all of this, it has been appearing to me that we wanted to shift this one to the first of the four parts, because it seems to have a lot of there's a lot of topic around it, and so I think it's good for us to go ahead and talk about this one first. So that's how we arrived here. Is everybody okay with that? Okay. I will introduce our dear panelists who are here with me. You are fortunate that I'm not going to do all the talking. They're going to do a lot of it. So we have Lynette, who's right beside me. Lynette is a relatively new social worker for independent living. We have beside her Kathy. And Kathy is not a new social worker. She's been with us for 23 years. So she has some tenure. And last but not least, we have Ann. And Ann is our clinic manager.
Hello.
Everyone, I think, knows Ann. And soon, I believe, we'll have Adrian join us. She was in a meeting and told me that it might go long, so she may or may not come, but if she doesn't, we'll pick up her part. Okay, so we're going to go through the slides, and we're going to talk first about Helping Hands, and a word about Helping Hands. It has been my understanding since I came to work here from Michael Shaw that Helping Hands was in the process of being eliminated. It was going to go away. And I believe that he said that. I wasn't here, but I believe that he said that to you in a public forum at least once or twice. And that's common knowledge, I believe. And since I've been here in my just under 4 months, what I've learned is that there's been a lot of contention about Helping Hands and whether it stays or goes or what we were promised or not promised, and all kinds of conversation about it. And so working with Ann and Kathy and Lynette, I've done a little bit of understanding about the history of Helping Hands. I've been working with a small group of residents, all of whom I think were pretty ardent supporters of Helping Hands. We've been meeting every month, every 2-3 weeks, something like that, in a group just to talk about this issue, so that I could feel prepared as we were walking through it. One of the things that I found is the history of Helping Hands. And there's some disagreement about this, so you may or may not agree with this history. But it comes from Lori Shepard, who was the person who really started Helping Hands. She was the clinic nurse. I didn't know her, but we've called her and talked to her about this, and did. And Amy Chapman. Some of you will remember Amy Chapman, who was the Associate Executive Director here, who's now at the Hermitage Richmond, who was the administrative person responsible for Helping Hands. And the history of it is that there was a time when Cedarfield did not have enough rooms in assisted living to meet the demand from independent living. And so Amy, in concert with Lori Shepard, came up with a program designed to help people for a short period of time as a bridge until a room could become available in assisted living. And that's how Helping Hands started. These are the words from Amy Chapman and Lori Shepard. Never designed to be long-term, and always designed to go away once that demand and the need matched again. We at Cedarfield, as I've discovered, shot ourselves in the foot because we described Helping Hands, and I don't know why we did this, in our handbook. And we described it not as really a service that was temporary. And in fact, on the same page, not the handbook, but another document, we said it's short term, and then we say as long as possible in the same document. So we've confused people, and I think we should own that because that wasn't very smart of us. We didn't describe it well. But as it's grown, it's become sort of a yes, we can service. And so there are some things that we were doing in Helping Hands that we should have never been doing. Some of those things include medication administration. We're responsible for people's medicines, filling their pill bags, administering meds to them, and we don't have a license to do that. We are not licensed as a home care or home health agency. That's something we should never have been doing. It grew to where we were bathing people. What was supposed to be standby assist turned into, oh, I can't reach my feet, or can you get my back? And next thing you know, we're fully bathing people as their health declined. Should have never been doing that. We don't have a license to do that kind of work. And the other big thing we're doing is meal deliveries. Those are the big things that we're doing. We're also doing some smaller things like TEDOs and things. But as Helping Hands is winding down, one of the things I want to be sure to tell our resident body is, and I've told the committee and I've told the leadership, is that the resident leadership, that we're not abandoning people. There are some people who we were providing services for that we never should have been providing. And once discovered, we really had to stop doing that. But Ann and this group here, I think we can all say very honestly that no one's been abandoned. We have had to make some other arrangements for people doing things that we should have never been doing in the first place, and that's been in process for us. And I've met with a couple of those people myself. One of the things I've noticed since being here is that but there's been some brand identification. Helping Hands is good. Affirmation is bad. That's the main brand identification thing that I've noticed since I've been here. And I think one of the things that would be helpful to us as we start a conversation is to focus less on the brand name and focus more on the service. What do I need, and what is the service, and can I match the need with the service? And that's where I think where we need to start focusing our efforts. Because some of the things do have names, but it's more about what the service is. And so I just want to get all that out of the way and talk to you about that. And at the end of the presentation, if you have other thoughts or disagreements, or even after the presentation, you can certainly talk to me about those things. But that's been the process. So we're going to roll forward now into our presentation. And it is about services and how we support and how we help identify support options for residents in independent living. So, to set the stage, why do people move to a continuing care retirement community? Lots of people do it, and there's lots of reasons why. People enjoy a certain lifestyle here. They don't have to worry about housekeeping or cooking as much as they did before. Some people move here because of the opportunity for social connections, which is very important. People are not a little longer home by themselves, but they're engaged with other people. There's not the worries with home ownership. You don't have to replace your roof or do those kinds of things. And so it's very much lifestyle driven. But really, I think in the back of everybody's mind, the number one reason people move to our continuing care retirement community is because of the promise of on-site health care if and when I need it. A lot of people will say, yeah, we were going to wait, but then we had X event, and it made us start thinking. And that's the kind of thinking that people oftentimes get into. But what happens if you're here at the continuing care retirement community and you develop a health need that's not acute? You don't have to go to the hospital, or you don't have to get rushed into some emergency type thing. What do you do? What does Cedarfield do? And that is where we're going to jump off and talk about the kinds of services, not the name brands where they come from, but the services that are delivered for us. All right, we're going to slide back to that one, Adrian.
Okay.
Let's first get into defining the interventions for independent living. We're going to turn it over to Kathy and Lynette.
Hello, is it on? Yes. When people introduce me, they say, this is Kathy Moran, she's been here forever. Well, I actually haven't. I wasn't here from the beginning, but I have been here a good while. And I think that's important because I can see trends. I've been here 23 years, and when I first started working here, I was in independent living. And back then, the philosophy at Cedarfield is, you're coming to a continuing care facility. And when our assessments, the two tools we use, show that you need more assistance, you are moving. And part of that was we wanted to make sure that people's needs were met. However, the philosophy now is, which Lynette and I really endorse, it's not about what Cedarfield wants, it's what do you want? We're serving you. Some people say, Kathy, Lynette, when I need assistance with medicines or I can't remember things, that's why I'm paying all this money. Move me over to assisted living. Others say, Kathy, Lynette, you know what? We want to go out, as Ann laughs, feet first out of independent living. So again, part of it is viewing you all as individuals to see what your preferences are. So that's why we're kind of changing the philosophy where moving forward, they say, call your social worker. Because not everyone's needs are medical. Sometimes they are. Sometimes might have been exposed to COVID. I have something on my back that needs to be checked on. But other times it's, I'm a caregiver for my spouse who has dementia and I'm worn out. Or I'm really blue after COVID and I can't seem to get my mood back up. Or my daughter was just diagnosed with cancer and I don't know what resources are out there. So there's a lot of needs that we all have that aren't just medical. And that's why Cedarfield's saying, reach out to your social worker so that we can come and meet with you, find out what your preferences are, and also to understand how we best can meet your needs. So saying that first and foremost, sometimes it could be a short-term meal delivery, right? Say you've had a fever, you're not feeling well, and you just need meals for a few days. Or you've just left healthcare, and you're a little weak to walk all the way to the dining room. That's a short-term meal. Long-term meal was what Helping Hands did before. This is more, you need a meal for a few days, and you would, notify Lynette and I if we can help you with that service. The clinic, which is obvious, right? Think of medical. There's a medical need that you have, whether it be you need a blood pressure, you have a physical need that you're concerned about. That's another option we can obviously provide. And as Paul said, the home health visits. The thing to remember with home health, and again, this is just another option. It works for some people, it doesn't work for others. I will honestly say the best time I see it working is when people are leaving healthcare. What happens when you go to healthcare is sometimes the medicines that you were on before, that were on your vial of life, they've added some more. And now you're taking new medicines and you're not sure if they're okay with your old medicines. So what can happen is the home health nurse can come in and make sure, read your physician's orders and make sure that all the medications that you're currently on is current with what you are in your apartment. And the goal through all of this is to keep you as independent as possible. That is the number one goal. So when we talk about these services that we're offering to you, it's because we don't want you to have a return visit, say to healthcare, or we want to keep you in independent living as long as you want to, as long as that's what you're wishing. Some people don't. Some people say, Kath, I'm ready to go to assisted living, and we'll help you with that transition as well. Does that make sense? Lynette's going to talk a little bit more about the home care visits and our outpatient therapy, which is another resource that we can use here.
Hello. To build on what Kathy was saying with regards to healthcare visits, which a lot of times is called private duty. So the medication reconciliation that can happen through home health can be continued through private duty, which I think is helpful for folks if they need their pill boxes filled. Someone can come in and help them with that once a week. Some folks might have someone come twice a day. Private duty is really focused on those activities of daily living that we all do, and then more of those independent activities of daily living, bathing, dressing. They can help with light housekeeping, grocery shopping, companionship, toileting. So those are the types of interventions and supports that you can get through private duty home care visits. Outpatient physical therapy, occupational therapy, or speech therapies, those are here through Health Pro Heritage on site. So that is something separate than what you could get through home health care. They can do all of those services in your home, so you don't have to leave. Obviously, to do the outpatient services, you need to be able to get to the outpatient center. And so other question mark, well, what is that? I think that could be a lot of different things, and it's very individual. I think each of you have different needs. You see yourself having different scenarios in your life. So again, going back to what Kathy said, reach out to us. I think everything starts with a conversation. What do you see going on? What do you think you need? What have you tried before that's worked? What hasn't worked? How can we build on some of the things you might already have going on? Family supports, can they come in and provide any interventions? Assessments, Kathy touched on that a little bit, mini mentals. Referrals outside to therapeutic agencies. Maybe you feel like you need a little mental health support, but we can get you connected to a private therapist and or Deer Oaks, which we have here on site. Maybe getting on Dr. Shelp's schedule, to go in and talk with him a little bit and have him assess you or your partner. Let's see. Plan of care meetings if you're transitioning back from healthcare, making sure that your discharge plan is going well. If it's not, what can we do to help tweak it and make it work for you? We've got support groups here. Those are interventions that people can get involved in. And I think a lot of it too is maybe supportive guidance. Sometimes you just need to talk to someone about what you've got going on. You're not really sure what you can do next or what that looks like, and maybe you just not necessarily need to vent, but you just need to talk, have it reflected back, and then be guided wherever you need to go. Advocacy, I think that's an intervention too. When Kathy and I meet with you all and you share information with us, what you think is important, what you see as critical in your daily life, this is your home, us sharing that with Paul and other administration, just providing that feedback. And how can we always make sure we're providing quality services? So that was it for the other.
Sounds good. Before we move to another slide, I want to just quickly touch base on the home health and the home care, because it's confusing.
Yes.
They both start with the same word, which is home. Home health is more medical and short-term in its nature, home health. Oftentimes, Medicare can cover the cost of home health, wound care, making sure you're safe in your home, which is how home health therapy comes into play. Home health is short, it's more acute, and it can sometimes be covered by Medicare. Home care is a different thing. It's a different license. And it provides more assistance for daily living. Help getting the laundry done, help with medication administration, help with just a private sitter might be in order. There's no third-party payer that pays for that service. It's typically a private pay type of thing. Home health and home care are two different things. One's longer term and private pay, and one's shorter term, more acute, and is often covered by insurance. Okay. I want to go back up a slide because one of the things that we, in preparing for this presentation, one of our resident committee members said, you know, you would do well to explain to residents again what the health center is for. People sometimes have the feeling like it's a hotel, or maybe I've got a little stomach upset, maybe I should be admitted there. So what is it and what is it not? And so Adrian is going to talk just a little bit about that.
Good afternoon, everyone. It is not a hospital, so if you feel sick enough to think I should go to the hospital, please do that versus asking to go to healthcare. Because even if you come to healthcare and then you're assessed, you may still more than likely be sent to the hospital. You know how you feel and you know what's needed for you better than any health professional starting off. So if you have that need or that urge that I might need to go to the hospital, choose that over asking to be admitted into healthcare. Healthcare is a step below the hospital. And what that being said is we get information and orders from the physicians on how to help you recover. For example, if you, unfortunately, and I pray no one does, fall and break a hip, you can come and get your rehab and services like that after you get discharged from the hospital, so that we make you stronger, hopefully make you strong enough to go back to your independent living apartment. Isn't an ER. In given situations, ERs have physicians 24/7, every single day. If you think like there's a fall, the nurse that's on duty, even if after hours or weekends, will come to your apartment, assess you, but send you to the ER. They don't have the skill set of emergency medicine. In healthcare and in the medical professions, there's various levels of skill sets. Our nurses are excellent nurses. They are good at the things that they are tasked to do. However, they're not ER nurses, and we don't have ER physicians on staff. So the two things we are not in healthcare is a hospital or an emergency room. Our goal is to help you get to your highest level of functioning or back to where you were prior to any incident, so that you can go back to your independent living apartment if that's appropriate. The second question is, can I go if I'm not feeling well and need a little support? If you're just not feeling well, I would ask that you go see Ann in the clinic first, let her assess what's going on. View us as, us being healthcare services, view us as the second step from either the hospital or from the clinic. The likelihood that we would admit you straight from the clinic into healthcare needs a doctor's intervention. The nurses and the staff and the team members try very, very hard to meet all your needs, but we want to give you the appropriate level of care. One example that was given, that a resident went to the hospital to have a pacemaker placed, and then from the hospital, they were going to send them back to their IL apartment. They requested to go to healthcare. There was really no need, if the hospital assessed you, to go back to your IL. That's where home health care can come in, do an assessment. People heal better in their own environment. People heal better if they're around their own personal things. healthcare can be an added stressor, and it can sometimes be a psychological safety net. However, if it's not where you need to be, we don't want to add that burden onto you. I hope I'm making sense to everybody.
Very good. Thank you. Thank you. Thank you, Adrian.
I was just going to add one.
Okay, Kathy's going to add one more thing.
The only thing that I wanted to add on is that I just wanted to clarify, we do allow you to stay in independent living if you need services, but to be fair and realistic to you all, you still have to qualify for independent living, and that's where the private duty or the home care comes in. So you have to understand, if you choose not to use through the continuum, then that cost will be incurred by you guys.
Okay, so now we know the healthcare is not and what it is. We know that it is staffed with nurses, and it implements doctor's orders. Oftentimes, you need to go to the hospital first so we can get the orders, and then you come back with us and we implement them. Doctors check on you periodically to be sure that their orders are still efficacious and are being administered correctly. We now know we have lots of different ways and different services that can be provided to you in independent living, like meals. The clinic is there. Home health could be recommended to you. Home care might be recommended to you. Outpatient physical therapy if you can walk to the gym, and lots of other things as were described. I think one of the best ways that I learn is through scenario thinking. What if this happens, then what happens to me in this case? And so we thought Ann might just run through some potential scenarios with you so that you can see how these services might be applied in the real world.
So the first one, I go to the hospital and they discharge me to my apartment or my cottage, but now I see I'm not 100%. So what you would want to do is call your social worker. The social worker can assess to find out, maybe you need home health, maybe you need home care, maybe you realize that, okay, I was too excited to get home and it is too much, and this is where we overlap with healthcare. And so we might find out that it was too much. The pain is too great, you can't get around, and so we'll get in touch with healthcare. Adrian, Tamika, the social worker, will help. We need a doctor's order to come up. But once again, you've already been to the hospital, and that's what Adrian's talking about. You just were a little excited about getting home first. And so social work will help with the clinic to get you back, to get you up to healthcare so that you can get back to your apartment or cottage. Another one, I have a wound from the dermatologist or any wound and I can't change the bandage. So the dermatology, I have seen so many people with the skin cancer, Mohs surgery. The clinic can still do that and change that. Anything that where there could be an actual wound, that you have doctor's specific orders for a surgical wound, maybe there's an infection there and you've been to a wound clinic, that's really where you want a home health nurse to come in. They know more than I do about this wound, and you want them to follow up with the wound center or whatever doctor is giving that orders, and they'll monitor that and they'll be able to get orders changed based on how the wound is doing. How about I get the norovirus or the flu and I'm going to be laid up for a few days? That's where the clinic can help. We can get the bland meal. If you're really sick and dehydrated, we can call Dispatch Health to come in. They'll come to your apartment or cottage, find out that you're dehydrated, and they can hang a bag of fluids right there in your apartment. You don't want to leave. You feel so awful. Healthcare doesn't want you. Right. Yeah. I can no longer manage my medications. What do? Once again, you call the social worker and they'll assess. Maybe we need home health in to see, is something going on? Or maybe it's a time for a change, and that's where social work will come in. Here's one. I can't get out of bed due to a flare-up of arthritis. So of course that would be something you would pull your cord or press your pendant, because that's emergent. You're independent. You should be able to get out of bed, get dressed, and get moving for the day. But if you can't get up, something's going on. We can't help you other than we'll assess you, and more than likely you're going out to the hospital to see what's happening, and then we go from there. Like I said, we're certainly going to help get you up, but there's something else going on if you can't get out of bed. How about, I'm feeling overwhelmed as a caregiver. That's where social worker would come in. You share your concerns, and the variety of scenarios or options that Lynette and Kathy shared with you are what they can help you with. I fell 2 days ago and I'm sore, I can't function. Adrian brought that up. So you fall, you jump up, I'm fine, I don't want to go to the hospital. And then 2 days later, you're like, I can hardly move. So before we say we're going to healthcare, everything, even in IL, in independent living, we need to talk to the doctor and get orders. So we would be in touch with your doctor. Maybe it's just a mobile x-ray in your apartment or cottage so that you don't need to go out. Or maybe we find out that the pain is even worse, so you do need to go out. Maybe you'll end up in healthcare. So a lot of these are specific where you're starting with the clinic or a social worker. I can't dress or bathe myself anymore. So we're going to get the social worker involved. You might end up having home health come into your apartment or cottage. You can't make it to the outpatient gym, so they're going to come to you. That might be able to be fixed in that time, or a social worker might be talking about, is it time to move to the next level of care? That's a conversation to be had, or if you're going to stay there with private duty. So those are some scenarios.
I don't know if, hello? I don't know if that's helpful to you. It's helpful to me, I think, to think through how does this really work in the real world? And you can come up with limitless scenarios. One of the common themes I think you just heard is call a social worker or call the clinic. And I think in this type of thing, there's two choices. We could try to get you to understand every single option that's available to you times 400 residents, or we can simply say to you that these people are the professionals, they already understand all these options that are available to you. Just call them. And then they can talk with you, your adult children, or your spouse, or whoever it is, and find out what's the best solution for you. Starting with Lynette or Kathy, you can think of it as a single point of entry health system in a way. And they're the single point. If you have a question, you can call these folks and they can get you to where you need to be. I think we as a community will always practice the least restrictive environment possible. We'll recommend to you or your family the least restrictive thing. If staying at home is the least restrictive, then that's what we're going to do. There are times when a person is not functioning well and is a danger to themselves or to others. For instance, this is the third time I've burned something on my stove, and it was a serious thing. Well, you're going to cause a fire because you have this person in this scenario might have some early onset Alzheimer's disease. They're burning things because they can't remember. It is irresponsible for us to just sit and watch that. So we'll make some serious recommendations about that person being in another living area or having someone who can watch them all the time. A person who is chronically going to the hospital because they keep taking their medicines wrong. And it happens a lot. That's a situation where we can't morally just sit by and watch a person kill themselves because we want to be in the least restrictive environment. So we have to talk with you or your family about, interventions. It could be in your home, but you'd have to hire someone to help you with that, or have an adult child come in and help you with it, or moving to a place as where we do that, which is assisted living. We provide medication management there. We don't provide it in independent living. So there are some situations where it's not just an inconvenience, but it's really dangerous to you or to the rest of the people that live here. And so we really are bound to have very difficult conversations with you or your family member about that. And some people make a choice. Some people say, I've got the resources and I'm not moving to assisted living, so I will pay for 24-hour care. And that's fine. No one is going to get mad about that. And other people say, it's time to move to assisted living. Or some people say, I'm not going, and their adult child, and the staff say, yes, I'm afraid we really have to. Or we have to find some else place to live, because we can't just sit by and watch you hurt yourself, because you just don't understand the depth of the problem. So those are things that we have to do sometimes. Okay, in wrapping up and then taking your questions, just reiterating about Helping Hands. It's a service that had always planned to go away. During the COVID crisis, it got ramped back up, and now the crisis is going down, Helping Hands is going down. I really want us to try as a community, if we can, to focus less on brands and more about service. Home care, home health, all those kinds of things. Again, you don't need to memorize all this. These ladies have already memorized it. They do it for a living. And then we'll open it up to discussions and questions. And I will play Donahue so you can ask these ladies questions. Any questions? Yes, there's one. The first hand was back here.
I know some of these names, but possibly others don't. I know Kathy Moran, I know Ann Hopper, and I can't think of Lynette's last name. Could you tell us your last name?
Murphy.
Thank you.
Thank you.
Thank you. The second question was on the front.
That was an easy one, all right!
Who had the question?
Yes, I just wanted to ask you about how does Medicare play into these services? How do you have to pay out of pocket for some services? And you have two levels or two different plans that you're dealing with here, the life care and the preferred choice. And I think that there's some confusion over that because it makes a difference whether have a life care plan or if you have preferred choice.
I can try to talk about that preferred choice of life care. So preferred choice of life care, preferred choice, you're going to pay for some things out of pocket that you didn't pay for if your life care, because your insurance fee was higher and your monthly service fee is higher. The most acute one of those things is the cost of care in the assisted living or nursing, where the cost is going to be more than daily rate. And in life care, it's going to be a discounted rate, a severely discounted rate. In the case of home care or home health or all these kinds of services, I can't think of a situation where it would matter if you were a preferred choice or life care. Am I speaking incorrectly, any of our panelists?
That's only when you go through the continuum.
Yeah, only when you go through the continuum of care. There are other things like some housekeeping and meals and things like that.
Well, my understanding is that if you have to go to the health care center, or you want to go there, that you wouldn't have to pay if you are life care, but you do have to pay a considerable amount if you're not life care.
So I think I was trying to say that. I may not have said it effectively. If you're life care, you pay less in the health center. If you're preferred choice,
No.
you pay more. That is correct. Other questions? There are other hands. Let's see, there's one.
I get the impression that with Helping Hands, you're phasing out long-term meal delivery. The alternative for that is, my question, are you advocating DoorDash and Uber Eats?
Well, I can start the answer to that question. You're correct. Phasing out long-term meal. If you can't get a meal, physically can't get a meal, there's a lot more going on with you than meal delivery. They're not being able to come up to a dining room. So the idea is it's going to be meal deliveries for short term, 7 days. I can't remember the increments. 7 days or something like that. It keeps going, keeps going. We really need to have a bigger conversation about what's going on, because that signals something more serious. But go ahead.
Right, and I was going to say, what we're finding is we never intended for someone to stay on meal delivery, say in a cottage, for years. That's someone that's going to be isolated, and like Paul said, there's so much more if you can't fix a meal in your cottage. So if it comes to that person's not going to move up to the big house per se, or assisted living, then they are going to be responsible for getting a meal on their own, whether it be DoorDash, Uber Eats, we can deliver as from dining, and there's a charge for that to deliver.
But to be clear, if you currently are getting those meal deliveries, you're going to continue. We're not going to just drop you. We're going to continue to do that. New people coming on, though, sort of there's a mark, and if you're currently getting it, we're going to keep on doing it because we don't want people to feel abandoned. I'm hesitant to do this, but I'm going to give the mic to Mike.
Go ahead and say
I was going to answer Carol's question the way I understand it. If you're on life care, you go to health care and you continue to pay what you're paying.
Correct.
If you're a preferred choice and you go to health care, you pay the rate of health care, memory care, or whatever that rate is. That's how I understand it.
That's correct. I'm so glad a resident could say that better than the executive. But you're right.
Some about weekend, if we have something coming on a weekend, who do you contact?
If you come up upon a weekend, who do you contact?
If you have an emergency, you press your pendant or pull your cord, there's always a nursing supervisor available 24 hours a day, 7 days a week. That's weekends and holidays. So when the clinic is closed, there's a supervisor for the whole building that is on staff through the night and the weekends.
We just learned there are 4 people that have opted out of the daily check program. And so I want to be sure everybody knows that if you opt out of the daily check program, meaning that we check on you every day if there's been no motion, we have no way to know if you're okay or not. So please be careful as you decide whether you want to stay in or opt out of the daily well check. Question?
I have a question about communications. Getting in touch with the right person and being able to get their attention is sometimes difficult. People in positions of authority have their phones set up so that you can't talk to them. You leave a message and you hope that you're going to get a call return. I think we need some kind of a filtration system where someone answers the phone, a live person, not a recording that says, "Your call is important to me. Please leave a message and I will get back to you," quote unquote. Then you wait and you wait and you wait and you wait some more, and nobody knows whether your call is important or not. And that needs to be filtered. You need to be able to talk to somebody at the outset who says, "I understand, we can't deal with you today, we'll deal with you tomorrow, or we will have somebody there in 10 minutes.
A good point, a complicated one, but a point well made. Other questions about interventions in the home?
I believe I just heard you say if you're getting long-term meal delivery, that will continue. So that will continue for the next 20 years?
So let's be clear. There was a time, and that time is now over, when a person would get on Helping Hands. There are a certain number of people who are currently on Helping Hands. Today, no one else is going on Helping Hands. There are 7 or 8 people? 7 or 8 people who have been receiving meals ad nauseum forever and ever. It's not, number one, it's not healthy. Some of these people will never come out of their cottage. The only person they see every day is the Helping Hands delivery person. That's it. There's no way to live, in my personal opinion. And so as those people transition to another level of care, those numbers will become fewer and fewer. Did I say it correctly? Okay. And that is in the vein of, we don't want anyone to say, you abandoned me, because we are not doing that. But we did have to make changes to people who we shouldn't have been doing services in the first place, medication administration, bathing.
When it comes to weekend care, you need to utilize some individual responsibility, because if it is something that is super serious, i.e. you've cut an artery or something like that, and the blood is spurting everywhere, you don't need to be taking your time to call somebody up here on the weekend to come to you. You need to be calling an ambulance to come.
That's a very good point. I have found, not here so much, but in other communities I've worked, people get a little conditioned to pull their cords. And what I'm always saying is, if you have a clear emergency, like if you're having chest pressure and you're cold and sweating, you're vomiting, call 911, like right now. If you pull your cord, it's going to be a few mornings before we come, then when we get there, we're going to pull your cord. So everything's been delayed. If it's a clear emergency, dial 911 and then pull your cord. Because we can be on the way too, security can be notified. So that's one of the things we don't want you to get conditioned about. Use some judgment, to your point. And you had a response.
Oh, no, I was just going to add one thing. We're throwing a lot at you, and we're here, as you know, to speak to any of us. If I could just encourage everyone in this room, if you're thinking, do I call them or don't I call them? Please call. Because, it's probably fine. I'm the same way. Oh, my hip. Oh, it's probably fine. Well, then after a couple weeks, it keeps adding, and sometimes a little intervention can go so much further than, Ann and I and Lynette, most of the time, we're called in on acute situations. It's an emergency. And it's never nice to be in that situation. So if at all possible, if we can do any early intervention to help out, it's just so much easier for everyone.
And here's another question.
You mentioned that some people decided to opt out of the daily check-in. Well, I've only been here a little over a year, so I have to tell you my experience with those check-in calls. The sensor was located in the hallway, and I was getting up, going to the bathroom, which is right by my bedroom, and the sensor did not pick up my movement. As a result, several times I got a call or even a visit from the clinic. And it really caused me to start thinking about opting out. But then I got the idea, well, maybe the maintenance people can help me with this. And they came very easily, moved the sensor to where it would always pick up my motion.
Thank you for sharing that. Kent Rowe has a question. She's been very patient.
I would like to make a request. I was in healthcare back at the first of the year. And when I left healthcare, I got home to discover that I had been prescribed a visiting nurse, occupational therapy, and physical therapy without any explanation as to why I needed any of it. So I think whoever makes the prescription, which is probably your doctor, should come and speak with you and explain to you, I've prescribed these services for you, and this is why. And then you also need to understand that you have the option to say no.
Adrian, any follow-up? It sounds like a discharge plan.
I
Okay.
don't think I'm on, sorry. I think we just wanted to build on that and say that that should be covered if you're in healthcare during your discharge planning meeting. So if you are going to get home health care, an affirmation and or another home health agency is going to show up like that, we should be having a conversation about it. That's going to happen when you get home. A certain amount of folks are going to show up at your door to do an intake, to do an assessment, see exactly what you need. So I think we'll make sure that we're always having that conversation and make it clearer.
It's a discharge plan is an area of opportunity, I think, that we've identified. I think that we'll do one more question and then we'll close out. Yes.
Do we have an approved list of people that will do home when you need someone to come into your home to help you?
Do we have an approved list of providers? I don't know that we approve people, but we have people that other people have had. We don't want to approve somebody and then you have a terrible experience and you get mad at us. But there are some lists that we have that others have had good experience with.
But you don't go out on your own and just get somebody.
You don't have to go out on your own.
You could.
These people, call them and they will advise you.
But you could.
You could if you want.
I mean, if you could, you definitely could if you wanted to. What I always recommend is if someone's had great assistance, to tell Lynette and I, because you guys are word of mouth and you know firsthand if someone was really good. We used to have, so in healthcare, we have an approved list if you want a private duty because we have to have a contract with them. But if you're in independent living, you're free to use whoever you want.
Okay, because that's different than when we moved in.
Yes, ma'am, it is. That's what Ann and I were just saying. That they have to be approved. Right. Well, exactly. The problem is, as Ann says, when you go to healthcare, if that companion or private duty is not on the approved list, then you can't bring that person over. So it's easier to use people that Cedarfield has so that we can back them. And that way, God forbid, if you have to go to healthcare, they can follow you up there.
So the step is to
Come to us. Come to us, yeah.
If you've heard nothing else today, go to these folks. You don't have to memorize 45 pages of healthcare and all the descriptions of. You can if you want to, and it'd be good to be a knowledgeable consumer. But these ladies know exactly what they are. I'm thinking that our next Continuing Care 101 series will be about transitions through the levels of care. What is the nursing center in much more detail? What services does the assisted living provide? I think we may be able to get some panelists from people who either currently live in one of those areas or who have lived in them to talk about that. So we can just talk about how people get back and forth, what are the circumstances that can happen. All this is an effort to make sure that you're knowledgeable about the place that you live. Because I have the feeling that sometimes I don't know what that. But I also know sometimes people tell me things and I'm like, you never told me that. I'm like, yes, I did.
Question. Being a mother, a single mother, having an animal, and for myself, I've never had anything that happened from 9 to 5, Monday through Friday. Never.
That's so
I'm
accurate.
a city girl and all of the other things. It's these off times that are the hardest to make decisions and to talk about who pays for what.
Off hours, pull your cord. A nurse supervisor will come visit you.
Yeah, I can add.
And add about the pets.
Well, it really shouldn't take hours. If you're pulling your cord or pressing your pendant and you have a true emergency, hours would be terrible. So that shouldn't happen, and we should hear about it. But I can say that most of the supervisors have our numbers. So when things happen at night or on the weekends, we hear about it too, and not that we hear about it as a problem, but we can be part of the solution to help, so that that supervisor is not all alone. And Kathy was saying about the animals.
What do you want to say? Just that if you're single with a pet, and most of you probably have that, have an arrangement. Anne is so cute now, she runs around, what's your plan, what's your plan? It's because we're trying to avoid emergencies. So not that anything's gonna happen, but in that example, if you have a pet, God forbid you fall, God forbid something happens to you, who's taking care of that pet in an emergency? Just again, trying to plan ahead.
I'm familiar with a community who required everyone who had a pet to have a pet care plan.
Oh.
And it was, and if you said X person is going to take care of my pet, X person had to sign.
Yeah, we all have little things.
Yeah. Okay, good. Because oftentimes they say, my brother's going to do it. You call it brother's like, I ain't doing that. I didn't even know anything about it. We want signed. Question in the back. That'll be the last question.
So if we entered Cedar Field on the preferred choice and want to go to life care, can that happen?
I do not know the answer to that question, and I will have to find out, but I do not believe that's the case, but I will try to find an answer for you, Ms. McCoy. Okay, y'all have been a really good audience. I hope this has been helpful. Please give a hand to our panelists.